Let us now move on to autosomal dominant. Now, a couple important things about autosomal dominant polycystic kidney disease. Once upon a time, you might have, and I'm hoping that you haven't, so let's not really even talk about this, apart from the fact that you need to know that it's autosomal dominant. Now, the reason that we no longer call this adult polycystic kidney disease, and I don't want you to do that any longer, that's what I was referring to, is because as far as age groups are concerned, it could be all over the place. It could have young patients as well, but mostly occurs in adults. Autosomal dominant polycystic kidney disease, I cannot move forward without good conscience without telling you about a very important gene called PKD1. Luckily, ADPKD, autosomal dominant polycystic kidney disease, that gene that is seen 85% of the time with ADPKD is PKD1. Fantastic. That actually works out really well. That PKD1 is important for you to know, including chromosome 16. Now, PKD2 is seen in 15% of the time, while really your focus should be on PKD1. Next, bilateral cystic disease developed by 20-25 years of age. Now, next important point. These cysts that you're seeing in an older patient, well, does that mean that the kidney dies? No. Is that clear? At some point when we go through this table, we'll talk about this patient having ADPKD and the insidious onset of chronic renal failure. So when you have cysts in the kidney, it does not, I repeat, it does not mean the kidneys are dead. In fact, what's the big thing that you're worried about in a patient with ADPKD? Excess renin release. Really? How's that going to manifest? You've all heard of Barry aneurysm, have you not? What's a Barry aneurysm? That is a sacral aneurysm taking place most likely where? In the circle of Willis. If that thing ruptures, then your patient has the worst headache he or she has ever experienced. Welcome to subarachnoid hemorrhage. Interesting. Autosomal dominant polycystic kidney disease. Now, there are a couple other important side effects, not so much side effects, sequelae that we'll take a look at with ADPKD. All parts of the nephron are involved bilaterally. Once again, here, not only could you have cysts in the kidney, I told you earlier that when you do have cysts in the kidney, oftentimes you will find it in your liver. No exception here. However, this is an adult or older. What do you know about your liver? Oh, incredibly resilient, isn't it? Yes, it is. It's responsible for quite a bit of taking care of your toxicities, including ammonia. It's a huge detoxifier of drugs, as you know. It conjugates. It is extremely resilient, even to the point where it will regenerate. So as we get older and say that we introduce enough damage to the liver, is it possible that an adult that maybe congenital hepatic fibrosis that we saw occurring in autosomal recessive polycystic kidney disease is not seen here? Yes, very much so. So here, when we talk about congenital hepatic fibrosis and portal hypertension, that would be more about ARPKD or juvenile. Here, could you find it? Sure, but as I said, look for cysts in the liver. Pancreas and spleen could also be locations where these cysts could also be located. Now, with ADPKD, one of the big things that you're looking for is, in fact, hypertension, 80% of your cases, if not more. Stroke due to rupture of intracranial Barry aneurysm. Aneurysms in 10 to 30% of your cases, so that's no joke. And then intracerebral hemorrhage, all because of what? Hypertension. What's lacunar infarct mean? It means little blood vessels up in the brain in which they are undergoing infarction, lacunar infarct. The consequence, depending as to what part of the brain that little blood vessel is supplying, will then determine the clinical manifestation. If it's that part of the brain that isn't so important, then maybe perhaps not so much of symptoms of your patient. But what if it was a little blood vessel supplying the basal ganglia? We have issues with motor, don't we? You see my point. Lacunar infarct could be significant or insignificant in terms of its presentation. Let's move on. Chronic renal failure begins at the age of 40 to 60. You'll notice the following. I told you, and I mentioned this right off the back, that as far as ADPKD and cysts, it doesn't mean that you're going to renal failure immediately. So the chronic renal failure will take place, but it's a lot later in life. Look at what's bolded. slowly expanding cysts and accounts for approximately 10% of cases of CRF. And that would be the most common cause of death at some point if chronic renal failure does set in. But you do have time to properly manage your patient, is my point. Cysts in the liver, older patient, genes is what you're looking for. Hypertension will give you a clue and look for issues within the brain. Other associations, now make sure you understand this. Apart from our hypertension, we talked about variant aneurysm. There could be sigmoid diverticulosis. Where are you? Left lower quadrant. How's the patient going to present? Painless rectal bleeding. Hematuria, MVP. What's that mean? In cardiology, we talked about mid-systolic click. And what about that click? You want that click to be closer to S2 so that the murmur in between it is quite small. What else? Slight risk for developing RCC. Important associations, not seen all the time, but nonetheless, keep this in mind because when you're reading a clinical vignette, trust me, whenever these vignettes are being created, that'll be in a journal, boards, or whatever it may be, obviously it's being put in there on purpose so that it can clue you in on a diagnosis. Let's continue.